Hello viewers, I am Dr. Ritu, infertility specialist at Indira IVF Delhi, Patel Nagar. Today we are going to talk about what is Mullerian anomaly and what is their treatment. So first let's understand what is a Mullerian anomaly. In any female fetus, there are two tube-like structures called as Mullerian duct, which are named after a German physicist, Johannes Muller. And in the development of female fetus, these two Mullerian ducts are supposed to fuse together and give rise to the fallopian tubes, the uterus, the cervix, and a part of vagina. So if there is any abnormality in their fusion, it results into a malformation which is called as a Mullerian anomaly. Now the next question is, who gets it? So you can't pinpoint as to who is getting it, or you can't even prevent it. It is rather an uncommon anomaly. 3 to 5% of a female fertile population can present with it, or even girls at an adolescent age group. Now, is there any way of preventing it? So as I said, no, you cannot prevent it. But then how would you know that you have it? So that means, what are the symptoms? How does a patient present? So patient can present depending upon the type of malformation they have. If it is an outflow tract obstruction, then usually girls will present at the age of menarche with severe abdominal pain, but there will be no history of menstrual flow. Now, if they present with severe pain abdomen and no history of menstrual flow, the most common anomaly we suspect is a septum or obstruction. So that will be a vaginal septum. And usually patients do not have any symptoms in the reproductive age group, in the early reproductive age group, because they'll have normal menstrual function if they don't have any outflow tract obstruction. Then the first time they'll come to know is either when they have recurrent miscarriages or abortions, or if they have recurrent preterm deliveries. So that can happen when they have either a septate uterus, diadelphous uterus, bicornuate uterus, or unicornuate uterus. So what all names I mentioned are the kind of various uterine anomalies, or you can say Mullerian anomalies. So how do you diagnose them? Diagnosis is very simple. By a good 3D ultrasound or an MRI, you can differentiate, because these anomalies have very subtle differences which need to be diagnosed with diligence, because they have to be dealt with utmost care to give a good obstetric outcome. So next question is, how do you diagnose, or how can you differentiate between various anomalies? So now a septate uterus, if you look at it from outside, it will be normal. But in the midline of the cavity, if you see from inside, there will be a thick wall jutting inside. So that will divide the cavity into, you can say, into two halves. And if it's extending up to the full length, up to the external os or up to internal os, it will be called a full septate uterus. But if it's only dividing the cavity partly, it is called as a subseptate uterus. Then you can have a bicornuate uterus. Here you can say the Mullerian ducts have fused, but they're not fused fully. So at the fundus, you'll see an indentation, and the lower part of the cavity will be normal. This is a bicornuate uterus. In unicornuate uterus, only one of the Mullerian duct develops, so the other half would not be developing. So there will be a small uterus with a small cervix and only one fallopian tube. Then you have diadelphous uterus. Here the problem is that there is fully developed both the tubes. So you have a full uterus, tubes, cervix, and even the ovaries, which are not developed from mesonephric duct, but they are still there. But there is no fusion of both the Mullerian ducts. So you have two uterus, two and two cervixes. So these are the various common anomalies, and other than that, as already mentioned, there could be a vaginal septum. So these are the kind of anomalies we discussed. Now, how do you manage these anomalies? So management has to be done at a tertiary care center with a multidisciplinary approach. Now, if it is a septate uterus, you can do it in a daycare procedure using a hysteroscope. You insert it through the cervix under anesthesia, and looking at the extent of the septum, you can cut it using a small surgical instrument like a hysteroscopic scissors. But if you have other anomalies like uterine diadelphous, bicornuate uterus, or unicornuate uterus, You need not operate on them because that will decrease the tensile strength of the uterus. So depending on the type of anomaly, you decide whether patient needs a surgical intervention or patient doesn't need a surgical intervention. So now the last but the most important part of this topic discussion would be then what would happen to the patients for whom we cannot have any surgical or medical intervention. So these group of patients need a very good obstetric care, and they have to be counseled about the risk of abortions and preterm deliveries. They have to have a very vigilant care, antenatal care, and they might require a cervical encirclage stitch which can be put at around 13 weeks once their dual marker test report has come. If you have any query on Mullerian structure anomalies, you can please contact me on the number displayed on the screen. Thank you so much for your patient hearing.